Taking proper PPE precautions, BSI, is my scene safe?
Your scene is safe.
All right, based off of dispatch information, we have a mechanism of injury of a woman who has fallen, hitting her head on a dresser, possible neck injury, bleeding. Is this my only patient?
This is.
I'm going to go ahead at this time and contact additional EMS assistance, and I will be considering spinal mobilization given the MOI. We'll see a little more when we get inside. So as I walk up, see my patient is on the floor. She's got a little bit of bleeding coming from her scalp, so we'll address that, and immediately get some manual stabilization on the patient. Hello, ma'am, how are you doing today?
I'm okay.
What seems to be the issue today?
I just lost my balance and hit my head.
Okay, so she is able to respond to me, so I'll give her an alert on the APU scale for awareness, or level of consciousness, excuse me. Mechanism of injury, chief complaint is falling down and hitting her head. I don't see any life threats right now. This blood is bleeding profusely from her head, so I'm going to go ahead and apply immediate pressure to stabilize this, get the bleeding to stop. I'll have my partner do that. From there, I'm going to move on to ABCs, starting with the airway. I'm going to assess the airway. She is talking to me, so it is a patent airway. I'm just going to make sure I don't see any secretions or fluid I need to suction out. And I would insert an oral adjunct if needed, which I don't. Moving on to my breathing, I would assess the breathing. It is a little bit labored. She seems a little bit struggle to breathe a tiny bit. It's natural for her mechanism of injury. Then I would assure adequate ventilations, make sure she's breathing okay. Since she's having a little bit of a hard time breathing, I'm going to go ahead and hook her up to 15 liters per minute of oxygen via a non-rebreather mask. I would also treat any injuries to the airway that would affect her breathing. I don't see any, so we're going to go ahead and move on to circulation. I would assess the pulse, make sure she's got a pulse down there. I would assess the skin, her color, skin temperature, and overall condition. Is it wet, dry, clammy, you name it. I would also assess and control any major bleeding. I've done so on the head, don't see any else anywhere. And I would also care for shock. I've already got some oxygen. I would go ahead and have her lay flat with her knees down, put a blanket over. I'd put a blanket over, and given my primary survey, I'm going to go ahead and mark this patient a high priority transport. We're going to load up and go as quick as we can. Next would be history taking. I would attempt to take a sample, which is signs and symptoms, allergies, medications, past pertinent medical history, last oral intake, and events leading up to. While I was doing that, my partner, meanwhile, would be taking baselines. He would be holding stabilization for the neck, so we throw a cervical call real quick, have them take baselines quick. Then I would move on to the secondary assessment. I would palpate the scalp, a little bit behind the ears. I'm going to assess the ears, nose, and mouth for any blood, cerebrospinal fluid coming out. I'm going to flash a light, noticing pupils before the light and after for reactivity to the light. Moving from the head, I will move to the neck. I'm going to palpate the cervical spine, see if there's any dislocation. I'm going to check for tracheal deviation, any JVD, indicating a possible pneumothorax. Then I would move to the chest, assess it by looking at it, palpate by feeling, and auscultating, listening in. Moving on from the chest to the abdomen, I would assess, and then I would palpate each quadrant. If there was any pain of some sort, I would start in the quadrant farthest and work my way to that one last. And then I would palpate the pelvis, make sure there's no deformities and it's nice and compact there. If there's any obvious genital trauma, I would go ahead and expose and treat as such if needed, but there's not. Then I move on to the lower extremities. I would assess motor function, CMS, pedal pulse. Then from there, I'd move to the upper extremities. I would assess motor function, pulse, and then I would move onto log rolling my patient up, placing a long spine board behind them. And while they're up on their side, I would go ahead and palpate that lumbar and lower back just to see if there's any displacement there. Go ahead, put them on the spine board, immobilize their body, which is going to help treat any of those secondary injuries. I've already treated for shock and control the bleeding, so those injuries are taken care of. Then we would go ahead and load up and go, recess every 5 minutes, and take care of anything else on the way. That would be it.